I'm presenting today radiation oncology residency training in Saudi Arabia, direction attaining competencies. So the reason why we started this study is because we just launched the radiation oncology training program here in Saudi. It's a new program, and we just did these survey-based studies. It's a series of studies that are supposed to track the progress and pinpoint our deficiencies in training and try to help improve them and give them a little bit more. Can't move the slides. Second. This is just a glimpse of our beautiful country. Please do visit at any time and enjoy the food and the culture. Just a little bit of a background about this program and this study in particular. It started back in 2019, and because of the increased demand like of radiation oncologists in general in Saudi Arabia and globally. And this is our first conference as radiation oncology residents in Saudi Arabia. This is SOS, not just a cry for help. It's just a Saudi Oncology Society. We just happen to be standing behind it. And the whole purpose of this study, again, is to understand the residents' experience and provide insights to the strengths and challenges and areas of improvement in the program. And also to provide some objective feedback to both residents and program directors on a national level. So just to give some of you some context to this, I know not all of you are radiation oncologists, but so what we do normally, this is the workflow that we have, and we first see the patients in our clinics. We counsel them for treatment, and if we decide that this patient requires treatment, we'll simulate them in the treatment position, and we'll target, delineate our targets and the whole contour, and our targets will go for planning, and our medical physics team will be taking care of that. And after that, the patient will be having their radiation treatment, and we'll follow them after that. So all of that is sort of a long list of workflow and a long list of checklists that needs to be done throughout the treatment and throughout the preparation of treatment. So we have to kind of measure our training in every aspect of all of these steps. And that can be a little bit difficult to assess and to objectively assess in particular. So again, as we mentioned, that this study was mainly done to provide an objective baseline measurement, because this is a new program, as well as to improve the quality of training, and hopefully to design any targeted educational interventions in the future, and also to provide feedback to residents and program directors. So what we did is that we distributed a survey, an online survey, anonymously to our residents. At that time, we had 13 residents eligible for this study because we excluded all the BGY1s because of their lack of exposure to radiation oncology rotations. And we included only BGY2 to BGY4. Also putting things into context, we are a 5-year program. So at that time when we conducted this study, we had only levels from BGY1 to BGY4. We didn't have any BGY5s at the time. And they completed the survey, and we used descriptive stats to measure or analyze our data. This is just a sample of our questionnaire. And you can see that about only 2 of our residents here were at level 4, and a majority were at level 3. And we asked them a couple of questions. How do you review your contours and plans with your attending? Which medium do you prefer based on their preference? We asked them, why do you prefer this? Is it because it provides you a feedback in a timely manner, or provides you with a better teaching quality, or interactivity, or convenience for you? And other questions that we asked is that how often do you review your offline cone beam CTs? For non-radiation oncologists, the offline cone beam CTs are the CTs that we review from time to time to kind of make sure that the patients are being treated properly, because we're not the ones who are providing or giving the treatment at the time. Our radiation therapists are the ones who are providing the treatment. So at the time of the treatment, a low quality CT is obtained, and they matched the cone beam with the simulation CT to make sure that we are treating the same exact target that we simulated the patient on. And that has to be approved by a radiation oncologist every week. And if in case we have like SBRT cases where we deliver high dose per fraction, it has to be approved by a radiation oncologist on the day, on the treatment. So that we call an online cone beam CT approval, or and the other one would be offline, because we do it after the patients get their treatment. And other questions we actually surveyed were, do you get to get called during the online CBCT reviews or not? Because that's an aspect that is a core aspect of training that has to be kind of like integrated into our training, and why they weren't, for example, involved. And other questions, just to kind of focus on the main results that we had. Out of 13 eligible residents, 11 residents completed the survey with a national response rate of 85%. And when we asked them about the preferred medium of review, whether it's plans or contours, majority of them, about 82%, preferred that they reviewed their plans or contours in person. That's kind of intuitive, to be honest, because and the reasons why they chose that is because of interactivity and better teaching quality and feedback in a timely manner. And only two of them chose the hybrid method. The hybrid method included that the attending would review the plans or contours on their own, and they would give feedback later on to the residents. And they thought that this is more convenient, and it does increase the teaching frequency for some reason. And when we did ask about the online CBCT review involvement, a majority of our residents, unfortunately, said that they don't do that on a regular basis. About 64% reported that, while only 3 of them said or 7% of them, they do it 3 times per week, and 27% said that they do it bi-weekly. When it comes to their involvement in every aspect of workflow, because as you can see, we do have a sort of a long list of things that we need to do throughout the day and throughout each patient's treatment. About 55% said that they're sometimes involved in all aspects of workflow, and that is mainly dependent on their attending. And about 9% said that they are not. 27% said that they're always involved in every aspect of workflow, which is alarming in a bit. So The most important part, I guess, is that when we ask about the most deficient part of their training, most residents found themselves most deficient in CBCT review and approval, and most residents do not review offline or online CBCT reviews with their attendings. And when we ask them why is that, why aren't they actually reviewing the CBCTs, about 44% mentioned that they're not familiar with the review approval process because they were never involved. And another 1/3 said that they have a pretty busy service. Usually either assistants or specialists get called in. And about 43%, so the BGY2s said that they're are actually not involved because of the fact that it's not part of their daily training or their daily sort of like expectation to do. So as far as we're concerned, this is the first study since the establishment of the radiation oncology program in Saudi Arabia. And the majority of our residents expressed some sort of shortfall in the CBCT review and approval. About half of our residents felt that they are not involved in every aspect of workflow, while only 27% reported their complete involvement, indicating that their participation level varied, and it was based on their attending directions. While our results look a little bit alarming, it does sort of match our or the North American program deficiencies. While they're long-established programs, they still have a problem with involving the residents in every aspect of workflow, the CBCT review and approval, the confidence of residents in radiation oncology and CBCT approval and in plan evaluation was also limited in these long-established programs. So to conclude, we do need a continuous and unbiased assessment since this program is pretty new, but it's coming strong, I think. Majority of the residents reported the most deficient aspect of training is CBCT review, and most residents prefer to review plans and contours with their attending in person. Workflow integration does vary by attending and does vary by institution. And as I just mentioned, most of these core deficiencies are also identified in the North American programs, and they correspond to those found in our program. Unfortunately, our study is not without a limitation. We do have a small sample size because of how fresh the program is and because of how small the number of the residents are needed for radiation oncology programs across the world, I guess. The timing of the survey was also important because it was conducted in a newly established program, and we did not have any PGY5s at that time where we had the survey. And we may not have any sufficient time to have mature data. And due to the limited scope, we should have some sort of like, we should be cautious in generalizing these findings because it's pretty immature. And we do have a possibility of desirability bias because some of the residents might have chosen some choices that are maybe more appealing or may not reflect the real life scenarios. And we do also need longitudinal data, and that's why we're doing this in a series sort of manner to follow up the progress. So just a couple of questions that we're left with after this study, how can we actually enhance the CBCT and plan evaluation training with structured modules and assessments for radiation oncology programs? And what are some initiatives that can promote national and international collaborations for clinical and research exchanges? Lastly, I just want to have a special thank you to Dr. Abdullah Sahibani for overseeing this project and his dedication to improve the program to reach international standards, and all authors, all radiation oncology staff and scientific committee who are dedicated to advancing education and clinical practices, and my fellow residents also for their support and participation in this series. And thank you.
Immune checkpoint inhibitors have emerged as powerful tools in the management of cancer, and we all know that these are monoclonal antibodies which block the immune checkpoints and thereby unleashing the T cells, which lead to management of the cancers. But because these are going to act on the immune checkpoints and they are involved in self-tolerance as well as autoimmunity, these medicines can have a lot of side effects, that is immune related side effects, and endocrine organs also get commonly involved, and that is what I'll be discussing about. So can you see the slide on thyroid dysfunction now?
We can see grading system of specific endocrine toxicities.
No. Now I'm talking about thyroid dysfunction.
No, we are not able to see that.
Can you still see?
Yeah, now I can see that. Yes.
Now you can see which one?
Thyroid dysfunction.
Okay, so coming to thyroid dysfunction, it is one of the most common endocrine abnormalities that we see in patients of immune checkpoint inhibitors. So it ranges from a spectrum of hypothyroidism at one end to hyperthyroidism at one end, and majority of these studies have shown that it's about 5.5 to 7.8% hypothyroidism, whereas hyperthyroidism is about 2.4 to 3.7%. Now, what exactly usually happens is that initially there is a transient thyrotoxic phase, which is due to destructive thyrotoxicosis, destructive thyroiditis, and eventually it would evolve to a hypothyroid phase or a euthyroid phase. So basically, sometimes it might so happen that we might miss the silent or the transient thyrotoxic phase, and we might actually get the patient in the hypothyroid or the euthyroid phase. Now, hypothyroidism is the most common. It can be transient or permanent, and anti-TPO positivity is found in about 18 to 45% of the cases. Very rarely, Graves' disease has been reported, and thyroid-associated orbitopathy has also been found in some cases. Can you see the slides on signs and symptoms?
Yes, we can.
Okay, so both ICPI related thyrotoxicosis and hypothyroidism lead to signs which are, or symptoms which are basically mild or non-specific. So in terms of thyrotoxicosis, we can get heat intolerance, we can get tremulousness, we can get tremors, anxiety, hyperdefecation, and rarely thyroid storm. Whereas for hypothyroidism, we can get fatigue, weight gain, cold intolerance, dry skin, and constipation. But nevertheless, we need to keep a watch out, because majority of the cases, these signs and symptoms are very, very non-specific. So how do we manage? So basically, we need to monitor for a thyroid function test. Can you see the slide headed as management?
Yes, doctor, we can see that.
You can see that. Okay, so when it comes to management, monitoring of the thyroid function test is very important. What do we need to run? We need to ask for a T4 and a TSH, and sometimes for thyrotoxicosis we would need a T3 also. So in case of hypothyroidism, we get a low T4 and we get a high TSH, whereas in case of hyperthyroidism we would get a higher T4, sometimes T3 in case of Graves, and we get a suppressed TSH. Now, usually as it can very rapidly evolve and it can be transient and permanent both. So in cases of patients, those who are receiving these ICPIs, what we need to do is we need to monitor them. If a patient is diagnosed with hypothyroidism, then we need to start with levothyroxine at about 1.6 microgram per kg, and that treatment needs to be continued and the patient has to be kept under a follow-up. But if the patient is having features of hyperthyroidism, we need to keep in mind that it is usually transient. So in those cases, you will just need a supportive treatment like a beta blocker or maybe a glucocorticoid might be needed. Antithyroid drugs are rarely needed in these situations. Okay, so again, due to some issue, is my screen not moving?
We are seeing immune checkpoint inhibitors right now.
Yeah, fine. So coming to what should be done, the therapy should not be stopped. It can only be interrupted in patients with severe thyrotoxicosis, right? Now moving on to diabetes. Immune checkpoint inhibitor related diabetes is very rare, but it can be life threatening. So it is basically autoimmune mediated. And what are the characteristic features? It leads to rapid onset of hypoglycemia, and there is swift progression of endogenous insulin deficiency. So it has got similarities with patients of type 1 diabetes, where there is absolute insulin deficiency and there is a high risk of decay. And this is what needs to be kept in mind. The patients have to be counseled, because if there is a chance of developing decay, then they should have the preparedness with insulin and management. How do we diagnose decay? It's not just the sugar levels, it's also we need to look at the acidosis, we need to run in an ABG, ketone bodies, etc. So the presentation would be, these patients can either present with diabetes in the form of polyuria, polydipsia, etc., or there can be a frank diabetic ketoacidosis. So for a HbA1c basically gives us an idea about the sugar status, glycemic status in the last 3 months. So if it's a very recently diagnosed diabetes, HbA1c might not be that high. Second is C-peptide. C-peptide gives us an idea about the endogenous insulin production. So in those patients where the pancreas is destroyed or the insulin production is very, very low, the C-peptide can be a surrogate marker giving us an idea about the insulin status, insulin producing ability, the reserve in the patient. Pancreatic imaging. This can be done. It is going to give us an idea whether the pancreas have atrophied or not, whether there is any size of the pancreas, etc. And last is the autoantibodies. We know that there are several autoantibodies which are positive in patients of type 1 diabetes, so we can get the same here also. Management, like I said, counseling is an integral part, because patients need to be aware of the condition. Insulin, it's the sole treatment in those patients who do not have any insulin reserve, who present with DKA. DKA has to be managed aggressively with fluids, insulin, etc. And usually there is no role of corticosteroids in this background. Now moving on to hypophysitis. So can you see the slide on hypophysitis?
Yes, we can see that.
You can see that?
No, now it has gone back.
Now it has gone back, right?
Yeah, diabetes I can see.
Now?
Characteristic features.
No, all this I've already discussed. So
It's a little slow. The
it's,
slide movement is a bit slow, but it is
it's a
coming.
bit slow.
Management right now.
Yeah. Hypophysitis, has it come?
Yeah, now it has come.
Now it has come. Okay. So coming to hypophysitis, basically hypophysitis refers to inflammation of the pituitary gland. It can be either primary or secondary. So primary is basically when it depending upon the etiology, that it is involving the pituitary gland itself isolated, whereas secondary is when it is in association with other conditions, such as there can be tuberculosis, there can be a fungal disease, there can be infections, there can be granulomatous polyangiitis, and even these drugs, that is immune checkpoint inhibitors, these are all responsible for secondary hypophysitis. Another way of classifying hypophysitis would be depending upon the histopathology, that would be lymphocytic, granulomatous, xanthomatous, etc. So the incidence of hypophysitis due to CTLA, the immune checkpoint inhibitors, is that highest has been seen in combination therapy, followed by CTLA4, that is the ipilimumab, followed by the PDL1. it is more common in men, and this is where we need to just address one point, that is lymphocytic hypophysitis, which is the most common type of hypophysitis that we encounter on a regular basis, which occurs in women, especially in the late postpartum period as well as after delivery. That affects women, but this hypophysitis, which is ICP1, they have reportedly shown to be affecting more men. Now, why does this happen? Because majority of people, they are affected with melanoma, and melanoma is the place where there is a requirement of CTLA4 inhibitors or the ICP, the immune checkpoint inhibitors. And men are the patients who mostly get melanoma. So probably there is a reason that it has been seen hypophysitis is present more in case of males in these patients who are getting immune checkpoint inhibitors. But even after taking into account, they still couldn't give the explanation that why it occurs more commonly in case of men. Now, coming to the symptoms. So it has got a diffuse variety of symptoms. So I think, is it moving faster now? Because I'm discussing the symptoms. Are we on the symptoms page?
Yes, myriad of symptoms.
Yeah. So it occurs weeks to months after the immune checkpoint inhibitor therapy, and the symptoms can be very non-specific, like headache, fatigue, sometimes giddiness can be there, weakness can be there, sometimes there can be loss of libido, etc. But here again, mass effect is rare, because in those patients who are having lymphocytic hypophysitis or other causes of hypophysitis, what happens is that there is a significant enlargement of the pituitary, which causes an impingement on the optic chiasma. But here the enlargement of pituitary is relatively smaller. So that is why we don't really get the compressive symptoms. What are the symptoms that we get? Usually it is the anterior pituitary hormones which are affected, one or more of them. Central hypothyroidism is very common. Now, what are the features of clinical features or biochemical features of central hypothyroidism is that there will be low FT4 or low normal FT4 in a background of normal or low normal TSH, inappropriately normal TSH, right? So that has to be differentiated from non-thyroidal illness syndrome. Secondly, central adrenal insufficiency. This again can be life-threatening because it contributes significantly to the morbidity. What happens? The ACTH is low and naturally the cortisol is also low. So if it is not identified at the right point, then they have shown that it leads to a significant mortality as well as morbidity. So patients have to be treated with glucocorticoids. Now, how do we diagnose? There is a test called a co-syntrophin test. That is 250 microgram of cyanactin we push in, and we need to check for a baseline cortisol as well as a cortisol 1 hour after. So what really happens is that if it crosses 18, then that means that the axis has recovered. But there are also caveats here. If it's a recent onset central adrenal insufficiency, then there would not be enough time for the adrenals to atrophy. And in that case, we might not get the right results to interpret this. So that again is important. Coming to hypogonadotrophic hypogonadism, this is again another point where the LH-FSH can be low, but then again, sometimes these patients are so sick that that might lead to a suppression of the LH and FSH. Coming to growth hormone, prolactin and ADH, we don't really have a lot of studies which are giving us an idea about what really happens to this. Whether there is growth hormone deficiency or prolactin deficiency, we still need to have more data on it. Now coming to diagnosis and management. So pituitary enlargement, basically it takes time within weeks to months, and we need to rule out metastasis. Serial MRI is to be done to compare. What do we get in the MRI? We'll get a mild enlargement, and along with that, stalk thickening might be there. Chiasmal impingement is rare, which I've previously discussed also. And the monitoring has to be done both clinically as well as biochemically. How do we replace with the hormones? So here again, there is another point, that is, I think you have not got the slide on the management part, right?
The slide is of diagnosis and
Hormone
management. I
replacement.
think we are
Hormone
there.
replacement. Is it being shown?
No,
Not being.
no, it's an MRI
Yeah,
slide.
it's an MRI image, but I need to discuss regarding the hormonal. Can you see now?
Yeah, we can see it now.
Hormone replacement.
Yes, we can
Okay.
see it.
So levothyroxine has to be started at 0.8 microgram per kg. And always to remember that if there is a concomitant adrenal insufficiency, glucocorticoids have to be started first, followed by T4. and then gradually we need to titrate it upwards. The rationale for lower dose is that because it might be transient, we never know, it might revert back to normal. And monitoring, very important point is that secondary adrenal insufficiency is to be monitored by free T4 and not with TSH. Coming to adrenal insufficiency, this is known to all that it is recommended to start with glucocorticoids in case of adrenal insufficiency, and there is a protocol if there is an acute adrenal insufficiency associated with hyponatremia or there are other life-threatening situations, it has to be picked up really well. After managing the acute stressor, the HPA axis monitoring has to be done, and the steroids have to be brought down to the physiological state. So coming to the testosterone therapy in men and estrogen therapy in women, this again area is controversial. So it needs more data. Moving on to the last slide of this part before I go on to the last topic, that is the prognosis and the therapeutic decisions. So recovery from central adrenal insufficiency is rare. Recovery from central hypothyroidism as well as hypogonadism is common, and high dose steroid is reserved for severe hyponatremia, critical illness, and substantial mass effect. So that was about hypophysitis related to ICPIs. Now coming to the adrenal. So primary adrenal insufficiency is seldomly reported with ipilimumab, nivolumab, and pembrolizumab. It might lead to adrenal crisis. There might be a low morning cortisol, hyponatremia, and elevated ACTH. So in case of secondary adrenal insufficiency, we get a appropriately normal ACTH, but here we get elevated. Imaging needs to be done, and management, we need to remember that with primary adrenal insufficiency, it is with both glucocorticoids as well as with mineralocorticoids. Coming to parathyroid, hypoparathyroidism is a rare event, and if there is acute hypocalcemia, that has to be managed with IV calcium, and all other parameters need to be taken care of. Last but not least, we all know that glucocorticoids are used very frequently in patients with malignancy background or with ICPIs, and the side effects would be osteoporosis as well as hyperglycemia. So that needs to be attended. Sometimes we have patients receiving more than 100 units of insulin per day, but the sugars are not in control. Osteoporosis because of steroids need to be attended to. And last is risk of adrenal suppression. So long dose of steroids can cause a very long suppression of the adrenal axis, which needs to be managed and titrated accordingly from time to time. I think the slides are not moving, right? You're stuck at adrenals.
It's moving, but a bit slow.
Bit slow.
Yeah, we are on parathyroid right now.
Yeah, parathyroid I've already discussed. Have you,
Yes.
can you see the last slide? That is concomitant, high dose glucocorticoids.
Yeah, we can see that.
Yeah. So like I said, with glucocorticoids, osteoporosis and hyperglycemia need to be taken care of. So how do we look for this adrenal suppression? So every 3 to 6 months, we need to check for the cortisol, like whether it has improved or not. And we might need to run in a synaptic stimulation test so that gradually we can bring down the supraphysiological steroid dose to a physiological level. And once the axis has completely recovered, we can stop the steroids. So with this, I would like to end my presentation. Thank you very much for your patient hearing. And unfortunately, I won't be able to take any questions now because there's an emergency. So everyone is free to contact me in my email if they have any queries regarding this. Thank you so much.
Thank you, Dr.
Slide 1. My name is Yuki Yoshimatsu, and I work in the field of rare cancer research at the Tochigi Cancer Center. I would like to thank all the doctors involved for giving me the opportunity to present today. In my presentation, I will discuss the sarcoma cell lines that are being established in our laboratory. First, I will provide some background on rare cancers and sarcomas, and then I will talk about the current status and future prospects of cell line establishment. Slide 2. First, let's define what is considered a rare cancer. A rare cancer is defined as a malignant tumor with fewer than 6 cases per 100,000 people per year. There are as many as 180 types of cancers classified as rare. As shown in this pie chart, rare cancers include leukemia, malignant brain tumors, sarcomas, and others. Generally, malignant tumors are named based on the organ where they arise or the gene responsible for the abnormality. For for example, lung cancer or liver cancer. Each has its own distinct characteristics. In contrast, rare cancers are grouped together based on statistical frequency, not biological similarity. As a result, there is no common treatment or molecular background among them. For example, leukemia, brain tumors, and sarcomas are completely different diseases, making rare cancer research particularly challenging. Slide 3. Although each rare cancer type affects a small number of people, collectively, they account for a significant portion of all cancer cases. This slide shows the frequency of different malignant tumors. On the left, we see common cancers with large patient populations. As we move to the right, the number of patients decreases. Rare cancers account for about 15% of all cancer cases, more than some major cancers such as stomach or lung cancer. In other words, rare cancers collectively affect a large number of people and deserve focused research attention. Slide 4. This slide shows global statistics. In Asia, countries such as Japan, Taiwan, and Korea show similar trends. About 20% of all cancer patients in these regions are affected by rare cancers. Slide 5. As I mentioned earlier, rare cancers are diverse and have no unifying features, which makes it difficult to define clear research themes. However, clinically, they share a major challenge. The development of effective treatments has been delayed. This delay is mainly due to difficulties in conducting clinical trials and limited pharmaceutical interest because of small market size. These barriers are now being addressed gradually. Slide 6. The core issue is the lack of appropriate models for research. Without these models, progress in developing treatments is severely hampered. Slide 7. In this context, models refers to patient-derived cancer models, which are the main focus of our study group. These include cell lines, spheroids organoids, and xenografts. These models are essential for evaluating anti-cancer drugs and identifying therapeutic targets. Without such models, drug development becomes extremely difficult. The lack of patient-derived cancer models is a major obstacle across all rare cancers. Slide 8. Sarcoma is a rare cancer originating from mesenchymal tissue, characterized by over 50 histological subtypes occurring throughout the body. This diversity, both in histology and anatomical location, makes treatment particularly challenging. Sarcomas often affect young individuals and progress rapidly, highlighting the urgent need for effective therapies. Establishing diverse sarcoma cell lines is essential to better understand the molecular and therapeutic characteristics of each subtype. Slide 9. Sarcomas can arise throughout the body, reflecting their origin in mesenchymal tissues. As shown here, they most commonly occur in the limbs, 25%, but also appear in the trunk, head and neck, retroperitoneum, gastrointestinal tract, skin, and genitourinary organs. This wide anatomical distribution adds to the complexity of diagnosis and treatment. Slide 10. Sarcomas are genetically diverse and often difficult to analyze due to their complex molecular signatures. They include both bone and soft tissue sarcomas with a wide histological spectrum. Fusion genes are found in about 1/3 of sarcomas and are often subtype specific, offering important diagnostic and therapeutic clues. In addition to gene fusions, sarcomas exhibit distinct DNA methylation profiles and gene expression patterns, further reflecting their molecular heterogeneity. Slide 11. As shown on the left, the 5-year overall survival rate for osteosarcoma improved significantly in the 1970s. However, since then, there has been very little progress. Despite ongoing research efforts, sarcoma grades and survival rates have remained largely unchanged over the past few decades. Currently, there are only 9 types of anti-cancer drugs that are effective against bone and soft tissue sarcomas, as shown in the timeline on the right. These include targeted therapies and immunotherapies, but the development pipeline remains limited compared to more common cancers. Slide 12. Currently, we face a major limitation: the lack of reliable experimental models that allow for effective proteome analysis. Without these models, it is extremely difficult to identify biomarkers that could guide diagnosis, prognosis, or therapy. This slide shows several techniques used in proteomic research such as 2-D-D-I-G-E and reverse phase protein arrays. These methods are powerful, but they rely on well-characterized models to be meaningful. Therefore, creating robust models is a crucial step if we want to discover clinically useful biomarkers and ultimately improve outcomes for patients with sarcoma. Slide 13. This slide summarizes the process of biomarker development. After identifying candidate biomarkers, we perform functional analyses. Verification experiments are a critical step in biomarker development, but they require the cooperation of many researchers and clinicians to collect clinical specimens for validation. In the case of rare cancers, it is uncommon to have a sufficient number of clinical specimens from the beginning. Therefore, we aim to demonstrate that the candidates are functionally relevant biomarkers and use that data to engage with and gain support from clinicians for further collaboration. To clarify the functional roles of these biomarkers, patient-derived cancer models, such as cell lines, organoids, and xenografts, are essential. Slide 14. Research often begins with clinical observations, such as metastasis, recurrence, or treatment resistance. At the same time, hypotheses may arise from laboratory studies of molecular abnormalities. We believe that patient-derived cancer models serve as a bridge between clinical observations and laboratory hypotheses. Slide 15. In response to these challenges, we developed patient-derived cancer models, including cell lines, spheroid organoids, and xenografts derived from tumor tissue. Slide 16. This slide shows a screenshot from Cellosaurus. It provides information on the number of registered cell lines and summarizes them from various perspectives. Slide 17. We investigated how many sarcoma cell lines have been reported among the cell lines registered in Cellosaurus. To do this, we checked each WHO-classified sarcoma histological type to see how many relevant cell lines existed. Although Cellosaurus has a search function, it was not sufficient for our needs. So, we downloaded the full dataset from the area indicated by the red line on this slide and analyzed it using Python. Slide 18. This slide shows the process of systematic review, are registered in Cellosaurus. If you narrow down to Homo sapiens, you will get 97,000 strains, and if you narrow down to sarcoma, you will get 1,728 strains. Excluding the cell lines created by introducing genes into specific cell lines, the number of sarcoma cell lines was 1,013. This slide summarizes how 1,013 cell lines are reported and stored. According to the survey, there are 149 cell lines stored in the cell bank and 923 cells published in the paper. The 121 strains shown in red are easy to use cell lines because they are also in the bank when actually used for research and there is information in the paper. 62 strains are cell lines that are not stored in cell banks and have not been published in papers. Such stocks are virtually difficult to use. Slide 19. This slide summarizes the breakdown of sarcoma cell lines registered in Cellosaurus. What type of sarcoma tissue is the cell line established for? This slide is an excerpt of the top 20 that summarizes the number of established cell lines by histological type. 100 cell lines have been established for top 3 osteosarcoma, Ewing's sarcoma, and rhabdomyosarcoma. It is not clear why cell lines are often established for these 3 sarcomas. It is not the most common sarcoma, and there are other sarcomas as malignant as these 3. Slide 20. This slide summarizes the frequency of pediatric malignancies extracted from the SEER, Surveillance Epidemiology and End Results American Cancer Registry System. SEER is a cancer statistics database that covers about 26% of the American population. SEER data show that osteosarcoma, Ewing's sarcoma, and rhabdomyosarcoma are the most common pediatric sarcomas. Top 3, which has many established cell lines, one possibility is that osteosarcoma, Ewing's sarcoma, and rhabdomyosarcoma are also pediatric sarcomas, and sarcoma research in the pediatric field is more active than adult sarcoma research. There may be, and that may contribute to the high number of cell lines. Slide 21. to summarize the results so far. First, a large number of cell lines were established and reported for a very small number of histological types. Regarding why the establishment of cell lines is concentrated in some sarcomas, the tendency of established and reported sarcomas does not seem to be related to the frequency of occurrence and the number of cases. That has not been established even if the malignancy is high, so it seems that it has nothing to do with the malignancy. The reason why cell lines of osteosarcoma, Ewing's sarcoma, and rhabdomyosarcoma are well established may be that they are pediatric sarcomas, which may indicate the activity of the research field. Maybe. Slide 22. In such a situation, such measures can be considered from the standpoint of establishing a cell line. First, the policy is to concentrate on sarcoma tissue types for which cell lines have never been established, unless it is a cell line that has not been established because it is difficult to establish, I think. Second, it is possible to focus on sarcoma tissue types for which no cure has been established. Since it is a cell line that is indispensable for drug efficacy evaluation tests of anti-cancer drugs, we would like to prioritize the establishment of sarcomas for which effective anti-cancer drug treatment has not been established. But there are many sarcomas for which no treatment method has been established, so it can be difficult to target with this policy. Another option is to establish a cell line from the sarcoma tissue type for which tumor tissue is available. There are few sarcomas for which a sufficient number of cell lines have been established, and since any sarcoma is important for patients, I think there is an idea to work on what tumor tissue is available. With this method, you can concentrate your efforts where you have resources, so it is an efficient way to proceed with experiments. Cell lines that researchers I know are looking for. Since cell lines are a meaningful resource only after they are used, I think it is a good idea to create a cell line that has already been confirmed by the user. If you proceed with this method, you may want to conduct a questionnaire survey or a literature survey to find out the demand. As far as I can tell, there is a shortage of cell lines for most sarcomas, so it is possible that there is no research and there is no demand because there is no cell line. So just because there is no demand, I don't think it's necessary to make a cell line. About it. Slide 23. As I mentioned in the previous slide, there is a vicious cycle in which research is not conducted without cancer models such as cell lines, and there is no demand for cancer models. In vitro studies are rarely available. We believe that such a vicious circle of rare cancer research due to the lack of a cancer model exists in various rare cancers. Slide 24. Cancer model becomes available for such a situation, we believe that functional analysis will be performed to answer clinical questions. Then, the idea of a breakthrough treatment method by new biology will come up, and it is expected that the research results will be returned to clinical and social situations. Based on this idea, we are creating cell lines for rare cancers and sarcomas. Slide 25. Using the established sarcoma cell line, we are conducting drug efficacy evaluation tests for anti-cancer drugs and conducting proteogenomics analysis in parallel. When there is a mutation in a gene that is considered to be a therapeutic target, is the corresponding molecular target drug really effective? And what is the molecular background of the efficacy of the molecular target drug that shows anti-tumor effect without the mutation? We are investigating whether there is a biomarker for predicting efficacy at that time. Slide 26. This slide is an example, but a drug efficacy evaluation test was conducted using an established cell line. The heat map shows the tumor cell survival rate when each anti-cancer drug is administered. In this group, the group on the left, the part surrounded by red, shows the effective drug group. Some of the most effective anti-cancer drugs were those that suppress the signal transduction system, those that suppress the epigenomics pathway, and those that inhibit the proteolytic pathway. Slide 27. Molecular level analysis, NCC oncopanel analysis, was performed to identify mutations in the target gene. We also identified treatment-related mutations from SNP array analysis. Mass spectrometry also identifies molecular pathways that can be therapeutic targets. We are in the process of integrating such data and conducting research toward the development of new treatments for sarcoma. Slide 28. By integrating various types of molecular data, we hope to better understand rare cancers and move forward with more effective, personalized treatment approaches. Slide 29. That's it. Thank you for your attention. I would like to express my sincere gratitude to all the researchers who contributed to this work. It was a great pleasure to share our findings with you.
In my PhD, I'm graduate in PhD student degree from Istanbul University. Right now, I'm a postdoc researcher at the same university. Today, I will present a part of a project titled Bioinformatic Analysis of Masquerading repair pathways activated in pristimerin-treated C41 cervical cancer line. So, sorry. In introduction, we know that DNA is a molecular repository of genetic information, so is constantly exposed to endogenous and exogenous damage agents. If we know that if the DNA is not repaired, we have some consequences such as mutation, cancer, neurodegeneration, or cell death. We have a subtype of DNA damage, single-strand breaks, double-strand breaks, base modification, cross-linking, replication errors. All this, all this DNA damage have a specific repair mechanisms. Here, if the DNA damage is not repaired, we have mutagenesis, cancerogenesis, apoptosis or senescence, and neurodegeneration. And here in our study, we focus to demonstrate the anti-cancer effect of bioactive compound replacement on C41 cervical cancer cells through the activation of DNA repair pathways. In parallel and methods, we have made the cell culture of our cells C41 in Y mouth MB mediums, and the component we use is a pristimerin. Pristimerin is a bioactive component extracted from different plants, medicinal plants. After we identify the optimum doses of pristimerin is 15 micromolars, and here after that we apply pristimerin in cells, and after that after 24-hour incubation, we RNA is isolated, and after that we make RNA sequencing. The steps of RNA sequencing. In the one step is total RNA. After that, we transform total RNA in cDNA. You have hybridization and exon ligation. You have amplification, and this and step we have a sequencing library. In here, in our study, we have two groups, control groups and pristimerin-treated C4 cells. After the isolating, the RNA sequencing library was created after the creation of the sequencing platform. We make data control and quality control. First, the raw data obtained in sequencing were converted and stored in FAST-Q, and then for the analysis of control at genomes or transcriptome matching, we use SOAP, NUC, and the hierarchical index of split element of transcript, respectively. Once the transcript model was created, the levels of gene expression, transcript, and exon were measured, and to map candidates to the reference gene sequencing, the BOSI package was used, and finally to analyze the gene expression, ReSame was used. And here, as a result, firstly, we analyze the RNA genome profiles. Here we have a differential expert gene were identified by comparing the control to the pristimerin-treated groups. And we identify that we have a total of 3,000 genes, around 3,000 genes. We have up and down-regulated genes here. And in cake analysis, pathway analysis, we observe that we have basic sexual repair, mismatch repair, homologous recombination, nucleotide excision repair was expressed. And we here in detail we have the basic sexual repair with the Q value. It's the Q value is equal to 0.002, and here we have this repair mechanism is regulated by 20 genes, and from the heat map we showed we have upregulated, downregulated genes and upregulated genes. In cake network, we observe that this basic sexual repair have a connection with the DNA replication, mismatch repair, and nucleotide excision. And in protein interaction, we observe that most protein involved in this repair mechanism have a node connection, a value of 19 or lower. And just we have one gene, the node connection value is 30. In this mechanism is after the recognition of the DNA basis damage, we have some steps here in the repair mechanism. We have the recognition, and after recognition have the excision, and here we have some protein like we have XPCC1, and here we try to give feeling to resynthesis DNA, resynthesis the base, and after that we have ligation steps, and we have the repair of this damage. In our study, just that these genes are expressed during the mechanisms, the repair mechanism. And here we have mismatch repair, which regulated in 15 genes. These genes, we have about 40 genes are upregulated and only one gene is downregulated. We evaluated data from heat maps. And here we have the PP analysis, which show that most protein have a node connection equal to 14, except MCH6. We have 30 nodes, the node value, and we have also MCHEK. The value of the node value is 13, and we have PL4, the node value is 12. And we have the cake network. We show that this repair mechanism have a connection with basic sexual repair, nucleotide sexual repairs. And another repair mechanism have mismatch repair. We also here we have the mechanisms, just that these genes are expressed in our study. In the they have the same steps in all repair mechanisms. Just they have differential genes are expressed here. In nucleotide excision repair, we have also we identified 21 genes. 21 genes, and here also we have the cake network. We show that this repair mechanism have a relation with cell cycles, basic sexual repair, and other mechanisms. Also, we have the repair mechanism here after the recognition of DNA of nucleotide damage. The damage nucleotide, we have also the processes of ubiquitin-mediated proteolysis. And here we have the excision of DNA synthesis, and the final step we have ligation. In the end, we have homolog recombination. We have in this repair mechanism is a process DNA repair mechanism that fixes the double-strand breaks by using a homolog sequence, usually the sister chromatid as a steplet. In our study, this mechanism was activated and regulated by the 20 genes from heat map analysis, and we identified the gene numbers. And we have also the K network. We show that this repair mechanism has a network with cellular necessors, base excision repairs. Also, we have the repair mechanisms here. After the recognition of the double strand breaks, we have the DNA synthesis, and here we have strand displacement and distant displacement, and finally we have the ligation steps. In ours, this study is this study is just a part of our project. After this study, we tried to make to perform some analysis like real-time PCR and Western blotting to enrich our study. In conclusion, here we before conclusion, we know that pristimerin have many study in this which evaluated the anti-cancer anti-cancer effect of pristimerin, but in the originality of our study is to evaluate the pristimerin anti-cancer effect via throughout DNA repair mechanisms. And in conclusion, we evaluated the anti-cancer effect of pristimerin on C4 as its cervical cancer, and we found that 4 DNA repair mechanisms were activated: base excision repair, nucleotide excision repair, mismatch repair, and homologous recombination. This pathway these pathways differ in both the nature of the DNA damage and the addresses and the repair mechanism they employ. Based on our result, we observed that pristimerin treatment caused various details of DNA damage compared to control cells, including base damage, nucleotide lesion, mismatched nucleotide, and double-strand breaks. Specifically, analysis of the base excision repair revealed in its involvement in necroptosis, its deaths throughout PERP1 and HME-YP1, and in autophagy via HME-YP1. In homolog recombination, we was linked to cellular resonances throughout these genes NBN. Furthermore, in mismatch repair, we have and nucleotide excision repair were found influences cell cycle regulation via the PCNA, and we have this gene CCNH and PCNA genes respectively. Our findings indicate that pristimerin induced multiple forms of DNA damage, such as base excision, double-strand breaks, and nucleotide excision. We know that for to repair this lesion lead to cell death and cell cycle arrest and senescence. The result suggests that pristimerin hold promise a potential anti-cancer agent by specifically targets key component of DNA damage repairs. Yeah, in conclusion, pristimerin, we can say that pristimerin has the ability to damage cancer cell DNA, inhibit the proliferation, and ultimately target programmed cells death mechanisms. And I want to precise that pristimerin have just a selective action, anti-cancer action for cancer cells, because we tested pristimerin in normal cancer, and we didn't observe any such toxicity. Yeah, and here I want to thank you for your listening. It's the end of my presentation. I want to sorry. Yeah, I want to represent the grateful response to my supervisor, Professor Dr. Gül Özcan from Istanbul University, for her support. Thank you all.
That was a
Thank you.
fantastic presentation, Dr. I'm here to give my talk on the topic, which is very close to my heart. So the topic is detection of circulating tumor cells by cell block technique in malignant tumors. I'm Dr. Janvi. I'm a senior resident in Department of Pathology in India. I'm a pathologist. So please go to the next slide. So this is my article that has been published in Journal of Cytology. I'll be reviewing it here. Next slide, please. And for that, I would like to give my special thanks to Wolters Kluwer Medno Publications for their permission. Next slide. So as we all aware, cancer is a leading cause of death worldwide and is a major cause of morbidity. In our country, in India, we have ICMR, that is Indian Council of Medical Research, which is the apex body in India for the formulation, coordination, and promotion of biomedical research. So according to ICMR, cancer cases are projected to increase to 29.8 million in 2025 from 26.7 million that was in 2021. Next slide. So circulating tumor cells are very important, as these are the tumor cells which originate from a solid tumor. They circulate in the bloodstream and they act as seeds for metastasis. So these are the driving forces of metastatic dissemination in cases of cancer. Next slide, please. These are new generation of non-invasive liquid biomarkers, and why they are important is for tumor diagnosis, for monitoring residual disease, for prognosis of the cancer, for metastasis, that how much has it spread, for knowing the response to therapy, and to know the recurrence of the cancer in the patient. Next slide. So various techniques have been employed in the past, like biological, physicochemical, electrical, and immunomagnetic for detecting CTCs. But these, as we can already understand, these are very expensive and they require a lot of capital and resources. And it is difficult to use them in resource-poor settings. So in our country, at very few institutions, we can actually do such expensive tests. So what I thought of doing was that I took an inspiration from this, and then I thought that something cheaper and easily available that can be done in a resource-poor setting should be done. So for that, I took up this study. Coming to the next slide, please. So one novel technique that was devised by Dr. Agarwal et al. In 2021 was the use of cell block technique from peripheral blood sample. So this procedure of cell block, which is done routinely in a cytopathology lab in India and elsewhere in the world, I'm sure, was explored in this study to detect CTCs. Next slide. So the objective of the study was to detect circulating tumor cells in peripheral blood by cell block technique in malignant tumors. Next. For this, the study was conducted over a period of 7 months, which started in July 2021 up till February 2022. The sample size was calculated with a relative precision of 10%, confidence interval of 95%, and power of 80%. And on that basis, the minimum sample size was found to be 97. But as all the consecutive cancer positive cases were which were diagnosed during the study period were included in the study, the final sample size was 112. Next. So all the new patients who were diagnosed with a malignant tumor of solid organs, either on FNAC or on biopsy, were included in the study. But the patients who have had any form of chemotherapy or patients whose diagnoses were ambiguous on FNAC and in biopsy were all excluded. Next slide. So for this, what I did was that peripheral blood samples, which were sent for routine blood investigations of these patients, were utilized. So there was no separate sample that was collected for this study. Whatever was being routinely sent for CBC was basically taken. So these blood samples were centrifuged for 15 minutes at 2000 rate per minute, first of all. After that, the Buffy code that was formed was carefully pipetted out to a centrifugation tube, and then 2 ml of 10% neutral buffered formalin was added to it. Again, the sample was centrifuged for 5 minutes at 2500 RPM, which is not a very tedious procedure. Next slide. The tubes were then allowed to stand overnight. Due to standing overnight, a button was formed of the cell block, and that cell block was put in the tissue cassette for further processing, like any other routine paraffin embedding technique of histopathology. And then the slides were stained with hematoxylin and eosin stain to look for circulating tumor cells. Next slide. These CTCs were screened under high power as well as under oil immersion, and they were screened by 2 pathologists who were blinded to each other and also regarding the site of the cancer. And ultimately, the presence or absence of CTCs was noted, and the number of CTCs, how many were found in each of the positive case, was also noted. Next. So how did I diagnose a cell as CTC? Why did I not confuse it with other blood-formed elements? So the criteria for a cell to be diagnosed as CTC was taken from Dr. Agarwal and L. et al., who said that a cell size of larger than size of normal blood cellular component with a visible nucleus should be taken as a circulating tumor cell. And on the basis of this, the samples were classified as positive or negative for CTCs. And the cutoff value of more than or equal to 1 circulating tumor cell was considered as positive. So on this basis, next slide. The cancers were all tabulated based on ICD-03, that is International Classification of Diseases for Oncology, 3rd edition, which is the recent most edition. Why this coding and tabulation was considered was to make the categorization of malignancies more uniform, as it is easy for the clinicians to understand that when the cancers are based according to the ICD-03 classification, to bridge the gap between diagnosis by pathologists and to enhance its utility by clinicians for the treatment of the disease. Next slide. So coming to the results part, the total number of cases that were taken were 112. The age of the patients ranged from 23 to 81 years with a mean age of 51.5 years. Female is to male ratio was 2.05:1 with 75 women and 37 men. And out of the 112 cases that were taken, number of cases that were found positive for CTC were 6. Next slide. So statistical analysis was done by entering the data in Microsoft Excel and tabulated. Number of cases in each of the organ system with the percentages was also tabulated. Cohen's kappa was used to assess the agreement between the 2 pathologists, and the Cohen's kappa value with respect to detection and number of detected CTCs was found to be kappa equal to 1, with percentage of agreement being 100%. The CTC detection rate was calculated among all the malignancies studied. Next slide, please. So this was how I have tabulated all the cancers that were found. So based on ICD classification, as we can see, 1 case was found positive in the cancer of mouth, which is highlighted by a red box. Another case that was found positive was cancer of the glottis. That was also 1 case. Next slide, please. Then 2 cases were found to be positive in breast from C50.8 according to ICD-03, and 1 case of breast was found positive with ICD coding 50.4. So 3 cases of breast were positive. Next slide. The 6th case that was positive was from the cancer of cervix uterus. Next. So overall, CTC was detected in 6 out of 112 cases, making up to 5.35% of the total number of cases, out of which 3 were from breast, 2 were from subcategory 50.8 in that, and 1 was from subcategory 50.4. Apart from that, 1 case each was positive from mouth, glottis, and cervix uterus cancer with their ICD coding. Next. So this is a picture, as you can see by arrows. First picture labeled as A shows negative for CTCs. So this is from a cancer of stomach. And what is highlighted here is a lymphocyte, which is just slightly larger than the RBCs, which are there in the background. But it is not a very large cell. It's a moderately sized cell corresponding to the size of lymphocyte. But when you see picture B, which is positive for CTC in a case of breast cancer, you can see a very large cell indicated by arrow. This is a very large cell with large hyperchromatic nucleus and prominent single nucleoli. Similarly, in figure C, you can see 2 CTCs. In figure D, you can see 1 CTC in another case of breast. Next slide. In figure A, again, you can see 1 positive CTC for oral cavity cancer. In B picture, the picture is positive for CTC in a case of laryngeal cancer, which is highlighted by arrow. And in C, it is a case of cervix uterus, which is positive for CTC, showing a large cell with a highly visible nucleus and a prominent nucleoli. Next slide. Coming to the discussion. So our study was most corresponding to the study done by Agarwal and et al., which was done in 2021 over 30 cases of breast cancer by cell block technique. So Dr. Agarwal found out that CTC detection rate was 6.7%. There were other studies done by different methods. Till now, only this is the second study which has been done by cell block technique. Before that, only Dr. Agarwal et al. Has done that. Other studies have been done by different methods, but again, they were quite expensive method, difficult to be done on a daily basis. Zhang Q et al. Had done one study on 150 cases of GIST by ICET assay, where the CTC positive rate was 72%. El Morshidi S had done 50 cases of breast carcinoma study by flow cytometry, where he counted more than or equal to 5 CTCs per 7.5 ml as positive cases. Christophe Neely did 177 cases of metastatic breast cancer study by immunomagnetics and found out that the detection of CTCs is highly predictive of progression-free survival and overall survival. Whereas the present study, which is the most corresponding to Agarwal and et al., says that 112 cases which were studied of malignancies of various organs by cell block showed detection rate of 5.35%. Next. So to conclude, cell block technique is one of the most basic and effective methods for detection of malignancy, especially in resource-limited settings. So these cell blocks can be further utilized for additional diagnostic techniques similar to the ones which are applied on a routine paraffin block, such as IHC, which can help in further management of the patient. Next. These are some statutory declarations from my side. Next slide. These are the references. Next. 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 Thank you. This was my presentation.
It is essential to know the expected post-surgical imaging findings and should be able to differentiate benign post-surgical changes from suspicious breast lesions. Benign scars and other associated findings should remain stable or regress over time. Any increasing distortion, developing asymmetry, new mass, or changing calcifications mandate further evaluation. Imaging modality commonly employed are mammography, sonomammogram, MRI, PET-CT, and at times CT chest. Next slide, please. Breast conserving surgery for stages 1 and 2 includes lumpectomy and partial mastectomy. Lumpectomy almost always followed by breast radiotherapy. Mastectomy can be radical mastectomy or modified radical mastectomy, including skin sparing and nipple sparing mastectomy. Breast reconstruction, that is breast prostheses, synthetic implants, myocutaneous flaps such as latissimus dorsi flap, transverse rectus abdominis myocutaneous flap, and muscle-sparing free flap such as deep inferior epigastric perforator flap, autologous reconstruction, fat grafting, and nipple areola complex reconstruction. Next slide. Contraindications to breast conserving surgery may include multicentric or diffuse disease, persistent positive surgical margins, prior breast irradiation, unfavorable tumor to breast size ratio, and pregnancy because of the subsequent radiation therapy. Next slide. Post-treatment imaging for a breast conserving surgery patient, the commonest imaging findings are surgical clips and distortion at the surgical site, as well as overlying skin retraction. Skin and trabecular thickening can also be seen secondary to radiation therapy. Next slide. There's a CC view of a mammography. The arrow is pointing to the skin retraction. Along with it, we can observe surgical clips and architectural distortion. Next slide. This axial CECT chest. In this, the arrow is pointing in the left breast to the skin thickening. Along with it is the surgical clips and architectural distortion. Next slide. These are the series of CC view of mammography in 2008, that is showing progressive reduction in 2010, and then further reduction is observed in 2013. That is a positive sign. Next slide. This is CECT chest. On both sides, we can see a modified radical mastectomy changes. It's prophylactic on the right side. Next slide. Bilateral breast prosthesis, that is a subpectoral bilateral breast implants being placed. Next slide. This is a sagittal view CT image. In this, we can see the arrow is pointing to the subpectoral breast implant that is placed beneath the serratus anterior. Along with it, we can see the loculated pleural effusion observed along the fissure in the chest. Next slide. This is a sagittal MR-tituated image. On this, we can see the patient actually complained of pain. It was basically to look for any signs of intra or extracapsular implant rupture, but there were no signs of it. Superficial to that of the implant, we can see the arrow is pointing to a irregular marginated mass lesion. Along with it was a number of lymph nodes, and this turned out to be a recurrent invasive ductal carcinoma. Next slide. This is a CC view of a mammography. In this, the arrow is pointing to a thin curvilinear density that differentiates the tram flap from that of the native breast tissue. The tram flap is of fat density. We can see the surgical clips in it in the tram flap. Next slide. This is the MIP image CT, and this the arrow on the right side is pointing to the inferior epigastric artery feeding the flap. Next slide. Moving on to the post-surgical complications: seroma, hamartoma, infection, fat necrosis, lymphedema, residual disease, post-traumatic neuroma. That is very rare. Next slide. This is an ultrasound image of the breast. And this we can see there is an anechoic fluid collection with minimal posterior acoustic enhancement, which is consistent with seroma. Next slide. This is an ultrasound image, and this we can see there is a heterogeneous fluid collection along with internal septations within it. This is seroma. Next slide. The CC view of mammography, and this we can see there is a well-defined ovoid density, high density. Along with it is a surgical clips. This was a patient at 6 months follow-up. So this is consistent with seroma. Next slide. Next slide. Yeah. This is a CCT chest axial. In this, we can see the arrow is pointing on the left side to the collection present overlying the pectoralis muscle, and it is extending to the ipsilateral onto the same side of the axilla, consistent with seroma. Next slide. This is CCT chest. On the left side, we can see there's a rim enhancing collection that is consistent with hematoma. Next slide. This is the unenhanced fat T1 sac image. In this, we can see on the left side, there is a fluid collection that is hyperintense on T1 weighted image, which is suggestive of hematoma. Next slide. There's a contrast enhanced fat. Previous slide, please. Yeah, thank you. Contrast enhanced fat sac T1 weighted image. In this, we can see there is no enhancement, internal enhancement of the fluid collection on the left side. So it is consistent with the hematoma. Next slide, please. This is the MLO view of mammography. And this, we can see the arrow is pointing to this tram flap, which is of a fat density. The arrow is pointing to the coarse calcification that are present within the tram flap. So this is consistent with fat necrosis. Next slide. This is a CT chest axial unenhanced image. In this, we can see the arrow is pointing on the left side to the tram flap with coarse calcifications within it, which is suggestive of fat necrosis. Next slide. This was a 42-year-old woman with history of right breast cancer, and there is a bilateral modified radical mastectomy with implant reconstruction, and autologous grafting was done, which was cranial to the implant. And in the surveillance PET scan, it showed corresponding FDG avid lesion. Next slide. There's a contrast enhanced T1 weighted MR image. In this, we can see the arrow on the left side is pointing to a marginal enhancing lesion with central hypointensity. The same hypointensity we can see on the right side also, which is consistent with that of the fat necrosis. Next slide. This case, actually, the patient who went left reduction mammoplasty, and she complained of a palpable abnormality, but she was not ready for a biopsy, and MRI was done. So we can see in T1 weighted fat suppressed SACH image, in the left breast, there is a marginally enhancing lesion at the site of complaints of lump, and there was a hypointensity in the center. The same on the non-fat suppressed image, we can see the central hypointensity being, which was seen in unenhanced image, being hyperintense, so consistent with the fat necrosis. Next slide. This is moving to the next important complication. That's the residual mass. This is the lumpectomy bed. Surrounding the lumpectomy bed is a large heterogeneously enhancing mass lesion. Along with it, we can see the skin thickening and skin nodules being present. axillary nodes are also seen in. This is a case. This is the mammography image. The first one, the center is the ultrasound image, and the last is the MRI image. In this, we can see in the ultrasound image, we can see the margins of the lesion being very irregular, very nicely appreciated. And the same thing in the MRI, we can see there is a irregular mass lesion, superficial, which turned out to be a malignant. Next slide. This is a patient who came with the concern of a lump which showed an irregular, heterogeneously enhancing mashed lesion in the chest wall, with the vascularity being appreciated in it. And in the adjacent, we can see it is the mass is inseparable from that of the skin at the lateral scar. Next slide. This patient complained of erythema, and we were thinking of cellulitis or abscess at the side, but when ultrasound was done, we can see there is a heterogeneously enhancing mass lesion with a solid and cystic component. The vascularity is also being appreciated in the left pectoralis muscle, which was a suspicious for recurrence. This is a chest wall. Next slide. This is a axial CCT image. In this, we can see the arrow in the center, which is pointing to the fat stranding, and the bigger arrow is pointing to the expansile left pectoralis muscle. Next slide. This is an axial CT image. In this, we can see in the center, the arrow is pointing to an enlarging soft tissue in the chest wall, anterior chest wall, along with the destruction of the sternum. On the left side, we can see there is a increasing skin thickening. This was, and right side, we can appreciate the pleural effusion. This was consistent with metastatic disease progressing to involve the skin and the chest wall. Next slide. Moving on to the last and very rare complication, the post-traumatic neuroma. This is an ultrasound image. In this, we can see there's a well-defined ovoid hypoechoic mass, which is oriented palatal skin surface, and the vascularity being appreciated with the tail sign, and it is consistent with neuroma. Next slide. These are all the series of recurrence which is detected on follow-up. In mammography, the incidence of detection is 35%. On physical examination, it is 39%, including both, it is 26%. On a follow-up mammogram in the ipsilateral breast, we have to look into parenchyma for any new density, developing asymmetry, mass, or microcalcifications. At the site of surgical scar, we have to see whether it is stable, and special attention to be paid to the flap native tissue junction, where it is a commonest site for the recurrence. Then in the skin, we have to look for skin thickening, and for nipple, the calcification to rule out Paget's disease. Chest wall also to be looked at. And this is a contralateral breast. Then we have to, for lymph nodes, we have to look both on the ipsilateral and on the contralateral breast. Next slide. Whenever there is a new density, the approach to a new density is the mammography. When we look out or when we find a new density, then we have to do a ultrasound. In the even if it is a suspicious, even with well circumscribed margin, we have to rule out, we have to do ultrasound to rule out cyst, and then the biopsy should be performed. There should be radiological and pathological concordance, which is a must. Next slide. For a women with breast cancer who have undergone initial excision and have positive margins, imaging with diagnostic mammography or MRI can sometimes guide additional surgical planning. Women who have completed breast conservation therapy for cancer should get annual mammography and may benefit from the addition of MRI or ultrasound to their surveillance regimens. Next slide. So in the surveillance following completion of breast conserving therapy for breast cancer, negative margins with or without radiation and patient being asymptomatic, digital breast tomosynthesis and mammography are appropriate. Next slide. In the case of post-surgical excision for breast cancer, positive margin, asymptomatic, and initial imaging. For invasive breast cancer with or without DCIS, a negative margin is defined as no tumor or ink by histology. In contrast, guidelines recommend that margin for pure DCIS with or without microinvasion be at least 2 mm. Women with a personal history of breast cancer develop a second breast cancer at the rate of 5 to 10% within 5 to 10 years after the initial diagnosis. Next slide. The American Society of Radiology Oncology and National Comprehensive Cancer Network both recommend annual mammographic surveillance for women who have completed radiation therapy as part for breast conservation therapy, with the first imaging performed at 6 to 12 months. Other studies have found imaging before 12 months is not beneficial and leads to unnecessary additional imaging because of the acute breast changes. They're supporting the first mammography to be at 12 months after the last mammography. Most frequent imaging of the ipsilateral affected breast beyond annual surveillance mammography at 6 months interval for the first 2 to 5 years has also been studied. Two groups showed no benefits to this more frequent imaging. One study found lower stage of recurrence in women undergoing 6-month surveillance compared with annual surveillance. However, this may be secondary to decreased compliance with imaging recommendations in the annual surveillance group, and follow-up was insufficient to assess for any mortality differences. Next slide. Conclusion. Imaging the treated breast presents challenges most of the time. It is essential to be aware of the normal evolution of post-therapy changes to avoid unnecessary further workup and stress to the patient. To identify the tumor recurrence at the earliest. Next slide. These are all the series of references. Next slide. Thank you. This is my presentation.
Thank you, Dr. Anita. It was such a fantastic presentation, very highly informative.
Right away that our team of 3 co-authors, 2 of us are mathematicians, the third one is a physicist. Myself as the speaker, I am interested both in mathematics and physics, and I hope it is of interest to indicate that in the year 2024, in the book Proton Therapy, edited by Dr. Fitzgerald, we did publish a significant, I hope, chapter. And it is the question of proton therapy, right? And we pretend to explain what is proton all about. So it is a little bit of heresy with respect to the theoretical physicists, because they say that proton consists of 3 quarks. However, we were able to publish a few key articles that indicate that probably proton is imperishable, and it doesn't consist of anything. It is an elementary particle. And I would say, as a joke a little bit, that I think this is safer for cancer patients to know that proton is an elementary particle rather than it consists of quarks. The so-called multi-level model, which insists that proton is elementary, I understand that probably it is not quite a right place to speak about it, so it will be as little math involved as possible. But our group, which has other two co-authors, we also deal with the special and general relativity, and we actually pretend that there is a new stage in the development of those subjects, and thus let me indicate or just mention the meaning of the last line on the first page, that this multi-level approach, I hope it will be part of the holistic medicine approach, which hopefully some of you would agree that it does make sense in cancer patient therapy too. Can we go to the second page, please? Next slide. Thank you. So here are some parts of the chapter from the book. And of course, it is, you know what, my friends, it's difficult, very difficult to know, both for physicists, not just for medical workers, what the wave function of proton is. But I would dare to compare it with a mood of a person. Sometimes we are in a good mood, sometimes not. And why is it? Because our wave function, and the physics says that each object has its own wave function, but it can be in different states, so to say. Sometimes our mood is good, sometimes it's not very good. But anyway, mathematically, we can show pictures. So this is figure B4 from the chapter, the so-called no dent case. As you can notice, we have just single maximum there, right? And then the surface goes down. It is always positive, which it should be for elementary particles. And then the B3 case from the chapter is the so-called WD, which means with dent. It is the higher portion of the wave function. You see there is a dent on top. So there is a local minimum hidden below. This was a toy example, since only two space variables were involved. And in the previous example, all three space variables, I mean x, y, z, were involved. Next page, please. And see, we are getting closer to the original development, which I am trying to present right now. But let me only mention that the reality of the wave function, it was, and it is still, still is a certain enigma. But it is known that a substantial contingent of experts aligned with our standpoint that the wave function must indeed possess an objective and physical reality. And that's how we are trying to say, of course, myself as the speaker, I'm fascinated that we are trying to open the door to exploring correlations between our findings, which are mostly mathematical and they are physically interpreted, and the correlation with distinct designs of proton volts, so how which produce proton beams. Let me now try to present introduction to wave functions in pictures, so to say. So these 5 stages are written specifically for the current presentation. So here's the function of one variable. So on the next page, we will see the graph of this function. This is function f of x. So just function of one variable, one peak, right? One point of maximum. And in the second graph, you can see, I believe many of you have seen the graph of this function, the sign of x function. We are just on the next stage 3. We will illustrate, and let's move to page 3, please. Next slide, please. So this was f of x. In green, it was the sine function, and now we have the third function. Just perform point-by-point addition, and that's how you get the sum of two functions, because the totality of wave functions of proton, it is a so-called vector space. So you are able to add two elements and to get an element of this very space. Next slide, please. As I mentioned in the beginning, we didn't have with dent case for the three variables. So for x, y, z, that is our main goal for today's presentation, to try to find the with dent wave function, which depends on all three space variables x, y, z. But before here, see the one of the complications is that wave function, it actually has complex rather than real values. It is easy to draw pictures on the plane, right? Because these functions, the values of each function is just an ordinary number. So we can draw a point above input. We can draw the value of this input. But additionally, in the totality of proton space functions, different transformations are supposed to act. Namely, a transformation which moves each xy point of the plane into 1/2 of each coordinate, right? So this is a well-known scaling transformation, and if we perform certain calculations, we figure out that applying this transformation to our original f of x, we get the graph in red, the result of the application of this transformation. And scaling transformations are of fundamental importance in theoretical physics. Let's get to the next slide, please. So here's the trick. This is the result. See, the subtraction of one vector from another, or one function from another, it is the same as we perform it in two stages. First, we multiply one element by -1, right? And then we add these two elements. This is all allowed operations in the space of wave functions of a proton. You see what we got? We've got 2 points of maxima and 1 point of local minima. So it is a with dent case, right? We are able, having two no dent elements as functions, as vectors in our mysterious infinite dimensional space of proton wave functions, we were able to get a with dent element. So this is, let us try this trick for the space, for the infinite dimensional space of protons wave functions. I do believe that it's not very easy to get to those rigorous formulas, but still, let me indicate that this is instead of space-time event, and K is a certain 2x2 matrix. V is a two-dimensional vector, but unfortunately, which is a complication, it has complex rather than real components. Let's get to the next slide, please. So by this age, we hide the so-called event, which was introduced by Einstein and others, because our space-time is four-dimensional, right? If we introduce time, which is denoted x naught, and for x, y, z, let's for a moment use x1, x2, x sub 3, then we can arrange these four numbers into a 2 by 2 matrix, and it is well known in theoretical physics. So the values are now involve complex numbers, so we have to somehow to get to real numbers, which is known in theoretical physics. What we do, it is the so-called complex conjugations. So this star means that the product will end up as a real number. And so this is well known in theoretical physics. And this lemma 1 is an important result which we have obtained just 2 months ago. So what happens to our, if you remember before, what happens this with one maximum picture, what happens to this surface when we use scaling? Remember what happened to the curve when we use scaling? It became smaller, so to say. A similar thing happens here. We get the wave function of the same type, but which is defined not by W and V as before. It is defined by a W. What this sign means? Wave, right? W wave above and V wave above. So this allows us, again, like we did on the two-dimensional plane, consider the difference of two states of two wave functions. And we were lucky to get the result. Let's move to the next slide, please. And this is what we have obtained. See, there is the original one maximum. Remember, we have started with one of the states being with single maximum. So this was no dent. But if you notice, behind this peak, we have a dent. Of course, this is everything is above the z equals 0 plane, right? Because we cannot go in theoretical physics to, and it never happens that we do not get negative numbers, but there is a certain dent, so definitely there is a local minimum there. It is kind of moved away. We do not get to maximal like with curves, and here's the specific 2/3 being the scaling coefficient. Remember with curves it was 1/2, right? But, and I'm sorry, but just have a look how complicated the rigorous formulas are. So this number 2, and let's move to the next slide. Number 3. How much time left do I have? Deli? Can you hear me? Next
Yes, you have
slide,
time,
please. Can you
Alexander.
hear me? Thank you. So you can hear me okay?
Yeah,
Good.
absolutely.
So here, thank you. Here I explain, let's move back to our order notation for the space variables x, y, z. So then we add those two numbers. And here I'm explaining what do those symbols mean. See, here we have I, which I squared is -1, believe it or not, right? This is the curious thing about complex numbers. So these values are complex, but when we move to L times L star, then their product is a real number, and that's how we can do the graphics. At least I hope you can feel my excitement, because we did have a certain guess. We tried a simple example. It worked. Then we applied the same procedure here. And so let me indicate that it is, of course, if you remember the previous slide, there was a kind of three-dimensional picture, right? X, Y, Z as the vertical line, Z, another D as the vertical line. So this was in the assumption of this y equals 0 here. And I have to confess that we haven't got to the final what we expect, that we have a with dent wave function depending on all three space variables. But we are now pretty sure that maybe in half a year or so we will finish our mathematical calculations, and this is the story. This is the new it is already the new element of this mysterious totality of protons wave functions, because it is a new element. So let's move to the next slide, please. So here's our co-authors. So if you, the street I'm now on, it is called the most wise street in the world. It is academician Lavrentiev. I'm joking, but it's partly true, because there are 25 research institutes located at the 2 square miles area. Can you imagine? So it is really in the book of those records, being the most wise. And I was happy. I moved from the Volga region here to the Novosibirsk State University, graduated from it. So those are the references. These are our affiliations, and I'm really sorry for this mature mathematics. I was trying to make it understandable, and it is a logical stop now. Is it too early to stop the presentation? I'm happy I was able to produce it.
My presentation on the comprehensive methods for detecting BRCA1 and BRCA2 mutation in breast and ovarian cancer. It's a publication. It's a systematic review, which is first published in Asia Pacific Journal of Cancer Biology. So, starting next, the introduction to BRCA1 and BRCA2. So BRCA1 and BRCA2 are the tumor suppressor genes that play a vital role in repairing double. Now the importance of mutation detection. We just have the genetic mutation increases the cancer risk significantly and compared to general population, and identification helps in early diagnosis and tailored treatment. So several advanced molecular techniques exist for the mutation detection, and each with the pros and cons. Next. For the methodology, for this review, we searched three major bibliographic databases, which is the PubMed, Scopus, and the Web of Science. We focus on studies published between 2018 and 2023, ensuring we cover the most recent advances. We use keywords such as the BRCA and BRCA2 mutation, genetic testing and mutation detection technique in breast and ovarian cancer. We include only studies that detail the mutation detection method relevant to the BRCA genes in breast and ovarian cancer, and the article outside this time frame lacking methodological detail or unrelated BRCA mutation detections were excluded. This approach allowed us to provide an up-to-date and focused overview of the technologies available today. Next. So overview of the detection method. These are the multiple technologies for detecting BRCA mutation, each with a unique strength and limitation. These include the array comparative genomic hybridization, denaturation, high performance liquid chromatography, digital PCR, high resolution melting analysis, multiplex ligation dependent probe amplification, next generation sequencing, and sequencing panels, PCR-based methods, RNA-based methods, Sanger sequencing, single-strand confirmation polymorphism. Next. So continue with the array comparative genomic. We just go through some key points of these techniques and what are their limitations, what are the applications, and how to work. For array comparative genomic hybridization, detects the large genomic rearrangements and copy number variations. Then the high sensitivity for large deletion duplication, which is less effective for the small mutation. It uses fluorescent label test and reference tile on the macros array, useful combined with the sequencing for comprehensive mutation detection. And the limitations is cannot detect small mutation and they require complex analysis. Next. Denaturation high performance liquid chromatography. It scans for mutation by separating DNA fragments by melting profile, and it detects point mutation, small insertion deletions. It's a cost effective for initial mutation screening but less scalable. It's good for the high throughput initial screening, and limitations is the required sequencing confirmation limited to smaller DNA fragments. Next. For digital PCR, it divides a sample into the thousands of reactions for precise quantification. It's very high sensitivity and specificity, and ideal for detecting low frequency mutation. It's quantified target DNA without standard curves, useful for liquid biopsies and low DNA samples. Its limitation is a high cost specialized equipment and limited multiplexing. Next. The next method is a high resolution melting analysis. It's a fast, cost effective, high sensitive for point mutation. It's monitor melting behavior for PCR amplified DNA to detect mutation. It's closed tube system and reduces contamination risk. It's good for the first line mutation screening and confirmation needed by sequencing. Limitations are need sequencing confirmation for complex mutations. Next. The next method is a multiplex ligation dependent probe amplification. It detects a large genomic rearrangement and copy number changes. It's a high sensitive and specific for BRCA1 and BRCA2 lesions. Cheaper and faster than whole genome sequencing for LGRs, and limitations is cannot detect point mutation or small indels. Next. Next generation sequencing and NGS panels. They're the high throughput sequencing for multiple genes simultaneously detect point mutation, indels, large rearrangements, required bioinformatics for data interpretations, and the limitations are initial equipment software and its cost is high. Next. PCR-based methods. They include the qPCR, multiplex PCR, and allele-specific PCR. They are specific, specificity is high, sensitivity is good, and cost-effective for the good mutation, known mutations. Rapid and suitable for small-scale studies, and their limitation is limited for novel variant discovery. Next. The RNA-based methods. They analyze the RNA transcript to detect splicing mutation and expression changes. They include the RT-PCR and RNA sequencing. It's useful for understanding mutation impaired on gene expression. And the limitation is the RNA instability and complexity and have a higher cost. Next, Sanger sequencing is a gold standard for mutation validation. It's a higher accuracy for point mutation and small indels, low throughputs and costly for large-scale screening, often used to confirm the mutation detected by NGS or other methods such as PCR. Text. Single-strand confirmation polymorphism is a simple, cost-effective screening for small mutation. moderate sensitivity and specificity, and is useful in low sources settings for preliminary analysis. And the limitation is labor intensive, less suitable for higher throughputs. Next. Now they have a comparative summary table in which we have some different charts and tables which you show the BRCA mutation detection methods, the sensitivity, specificity, cost, and scalability comparison to all methods, mutation detection methods and attributes, counts of methods per application, mutation detection methods for versus features and strength, and sensitivity versus cost comparison. Next. Okay, this is a BRCA mutation detection method. So you see that almost 45% of NGS panels have the higher throughput board mutation detection, including the point mutation and large rearrangement. Then we have the PCR-based method, which have the 20%, which have the rapid sensitivity detection of known mutation and small-scale screening. On the third side, we have a Sanger sequencing, which is another the gold standard for confirmatory or testing of mutation. Then on the 13% is the ECGH and the MLPA, specialized for the detecting large genomic rearrangement and copy number variations. Then on a smaller side is 7% screening models of HRMA and DHPLC and SSCP used for initial mutation pre-screening. 2% is go for the digital PCR, ultra sensitive quantification of a low frequency mutation, and with the low frequency of RNA-based method detect the splicing and function mutations effects. Next. Okay, this is a comparison of detection methods. You can see that the different on the x-axis is a different methods which are there, and on the y-axis is a you show the levels which starting from the very low from 1 and the very high on the 4 digits, and on the side you should see the sensitivity, specificity, cost, and scalability. So throughout this we can see that the cost, the sensitivity and specificity of in this scenario, the methodology is go for the next generation sequencing and next generation sequencing panels is here. Next. Okay, it's a mutation detection method attributes. So it's a heat map of mutation detection method attributes. On the y-axis, you can see the different methods there, and on the x-axis is a sensitivity, specificity, cost, and scalability. On the basis of sensitivity and specificity, you can see NGS gene panels, next generation sequencing, and digital PCR is on the top. On the base of, we go for the cost effective. So again, the cost and scalability is much more lower for SSCP, and then go for the HRMA and PCR and so on. So according to the methodology and the sensitivity, specificity, cost, scalability, this table will be identified. Next. Okay. On the counts of methods per application. So you can see again, there is on x-axis, there is a application point of view, and on the y-axis, there is a scale which show the number of methods. So each which method is going for detect which applications. On the level of the detection of splicing, mutation, and transcript variants, they are the RNA-based methods. On quantification of low frequency mutation is a digital PCR, and mutation detection is very high. Methods which go for the PCR-based method, NGS and Sanger sequencing. On the mutation pre-screening and screening, they have the DHPLC, SSCP, and HRMA. And on the large genomic arrangement and CNVs, we have the ECGH and MLPA. Next. So mutation detection versus the method versus the features or strength. So you can see in this figure, the Sanger sequencing is have a higher frequency and accuracy, whereas the next generation sequencing is a high throughput, but it's required bioinformatics. In MLP and ACGH is digital large genomic rearrangement and detect the large genomic rearrangement. On the PCR-based method, we have this is a cost-effective, and again, it's limited for novel variants detection. For RNA-based detection methods, it's sensitive to express changes. And for the SSCP, it's cost-effective, but again, required labor-intensive. Next. Sensitivity versus cost comparison. So there's a different methodologies which we compare the mutation detection method versus sensitivity. You can see on the one, the detection is the ACGH. The sensitivity is 4, which is higher, but the cost is little bit low. DHPLC is again with a lower sensitivity and lower cost, whereas the digital PCR have a higher sensitivity with the moderate cost. PCR-based method is also on the higher side, a little bit higher side with the sensitivity, but the cost is also low. SSCP has a less sensitivity as compared to the cost is also less. The HRMA has a higher sensitivity as compared to the cost. Cost is very low. The MLP again has a higher sensitivity against the cost is moderate. But the NGS and NGS panel are the higher side of sensitivity, but then the cost of these are higher. Both the NGS and NGS panel. On the RNA side detection methods, the cost and sensitivity will be moderate. The Sanger sequencing has a higher sensitivity, and the cost is a little bit compared with the RNA-based methods. Next. So, okay, discussion and future directions. Different methods offer trade-off between the sensitivity, cost, and scalability, and combination of methods. Example, the NGS, MLPA, and ECGS, which can combine and improves the detection. Emerging technologies such as CRISPR-based diagnostics and the third generation sequencing. We have the ONT there, the PacBios there. We have the good emerging technology to detect the mutations. Need for affordable, accessible, and standardized tests in clinical settings. Next. Okay, the technologies which we are asking discussion about the emerging technologies. The emerging approaches such as CRISPR-based diagnostics and the third generation sequencing are promising rapid and highly sensitive and specific detection tools. The CRISPR performs like the Sherlock, enables point of care testing with the multiple capabilities. TGS, which is the third generation NGS technology, is the PacBio and Oxford Nanopore offer a long read sequencing ideal for detecting complex genomic rearrangement and epigenetic modification through cost and technical expertise, and remain the barrier for the routine use. Next. Now, choosing the right method. The optimal detection method depends on the mutation types, clinical and research context, resources availability, and required throughput. Often a combination of methods ensure the comprehensive and accurate mutations profiling. So depending on the mutation type, scale, cost, and available resources, we can choose the mutation method. Combining method and often yield the most comprehensive results. We get 2 or 3 multiple methods you can involve or combine it and get it the good results. And clinical versus research applications vary in the requirements. Next. On conclusion, the accurate detection of BRCA1 and BRCA2 mutation is crucial for cancer risk assessment and patient management, while multiple robust technique exists combining newer high throughput sequencing with the complementary method provides the best results. So molecular diagnostics and bioinformatic advances continue to enhance mutation detection, promising improved patient outcomes throughout personalized medicine. So the choice of methods depends clinical need, mutation type, and cost and resources. The high throughput methods like NGS are preferred for the large scale testing. NGS and combined approaches are becoming the standard for the comprehensive analysis. Confirmatory testing often requires Sanger sequencing or complementary techniques. Future technologies are promise they are faster, cheaper, and more accurate for diagnosis. Early and accurate detection improves patient management and outcomes. Next. Acknowledgement and references. Thanks to all the contributing researchers and authors who made this review possible for us. And for further details, please refer to the list of references you're already clicking on this paper. Next. Now the question and answer session. I'm happy to take your questions now.
I sincerely thanking the organizers and the coordinators of this webinar for giving me the opportunity to present. Today, I'll be sharing a fascinating case of the meningothelial hamartoma. So let's begin. So next slide, please. Like, as we all know, the majority of the tumors in the scalp tumors, 96% of them are the benign tumors. And among the benign tumors, almost 50% of them are the cyst, and only the 20% include the others, including the hamartomas and the nevus. Next slide, please. Yeah. So I'll just explain about first two terms, a scalp lipoma and a meningothelial hamartoma, because my entire case report is revolving around these two terms. So a scalp lipoma is a slow-growing fatty tumor, primarily composed of adipocytes, which typically presents as a smooth, round accumulation of subcutaneous fat with a rubbery texture upon palpation. While meningothelial hamartoma, also known as rudimentary meningocele, is a scalp hamartoma characterized by ectopic meningothelial elements. Next slide, please. So, a 6-year-old female presented to the OPD with the chief complaint of painless, enlarging lump on the left forehead region from the past 10 years. She had a negative history of fever and trauma, along with, next slide, please. Yeah, so here we can see as the lump. So this lump was 3 by 2 centimeters on the left frontal region. Yeah, next slide. Yeah, so she had a negative history of any fever and trauma, along with a negative family history or any substance abuse. During the physical examination, as I already told, like there was a lump measuring 3 by 2 centimeter, which was soft in consistency, non-tender, well-defined, and there was normal overlying skin. Next slide, please. Yeah. On doing the blood investigations, the entire labs were normal except for the reduced hemoglobin levels, which were 8.6 mg per dl. And on doing the magnetic resonance imaging MRI scan, we saw an oval-shaped hyperintensity in the left frontal region, measuring 2.6 into 1.3 centimeter with an intact cranium. You can please click though so the photo will appear. Yeah, as we can see in this picture. And an area of T2 hyperintense and FLAIR hypointense bilateral frontal and basifrontal lobes were seen. So these suggested there was intact cranium. So on doing the MRI, so the first DD which came to our mind was lipoma. And please next slide, please. So for further diagnosis, we did the FNAC and sent for the cytology, in which we saw may you please click, the image will come. Yeah. On doing the FNAC, we see the monomorphic sheets and clumps of round to ovoid cells with moderate amophilic cytoplasm. Nuclear grooving and intranuclear inclusion bodies were seen. There were no signs of mitosis, and only few multinucleated giant cells were seen. So based on the combination of this FNAC and the MRI scans, we made a DD of lipoma. So it was like a provisional diagnosis. Obviously, it was confirmed after doing the histopathology of the excised specimen. So after having a DD of lipoma, we did a surgery. Next slide, please. So on did so a total excision was performed and it was removed. So on the visual inspection while doing the surgery, we saw there was no cranial involvement. So we sent the specimen for histopathology. Grossly, it was pale, tan, soft tissue mass with a normal intact skin. Next slide, please. So on, may you please click the once again. Hello. May you please click once again? Yes. So on histology, we saw mature adipose tissue bands, as we can see in this image, which consisted of bundles and small nodules of dense collagen. As we can also see the meningothelial cells in nests and strands, giving a characteristic whorled appearance. So a whorled appearance is a characteristic of meningioma. So may you please click once again? So the previous image was under 40x. So this image is under 100x. As we can see clearly the whorls and interspersed with the depocytes. So next slide, please. So here we had an idea like it could be meningioma or meningothelial hamartoma. Obviously, meningothelial hamartoma had not come once in our mind like straight away because it's so rare. So we did the IHC to confirm it. On doing the HMB45, it was negative. Cytokeratin was also negative. Ki67 showed very low reactivity, and GFAP was also negative. Although a characteristic triad of vimentin was strongly positive, epithelial membrane antigen was also positive. And the main characteristic feature, the progesterone receptors, they also showed immunoreactivity in 20 to 25% of the lesional cells, which led us to confirm that this case is of meningothelial hamartoma. Next slide, please. See, in this, we can see this is the IHC. The two IHC you can see. The first one is for vimentin, and the second is for, please, may you please click it? Yeah, the second is for epithelial membrane antigen. Yeah, next slide, please. So outcomes, so the patient was normal and she was called up for follow-up after 2 weeks. There was no sign of surgical site infection and the lump has not recurred for a year. We did the follow-up for at least a year because according to the literature review, the recurrence has occurred almost 2 to 3 times in the previous cases. Almost 20 cases have been, only 20 cases have been reported so far. And majority of those also have been there in the posterior region of the scalp. And this is the first of the kind which is present on the frontal side and that also in the middle aged. Like either it was in the early age or it was in the late age. This is the case which was present in the middle aged women also. Next slide, please. Yeah. So just to have a simple discussion, meningothelial hamartoma is caused by the ectopic displacement of meningothelial cell precursors during the embryogenesis. And the characteristic two features, they are present in whorls and there is the presence of semoma bodies. Although semoma bodies was not seen in our case in the histopathology, whorls was present. So the first case in the children was present in the by the current Melendez et al. The reference has been given below. And they also presented a case in which the lesion was in the posterior region, as I already told it. So after having a discussion, so meningothelial hamartoma can be mistaken for various benign scalp lesions, including dermoid cysts, epidermoid cysts, pilometricomas, neurofibromas, and vascular anomalies, such as hemangiomas. So to rule out these, dermoid and epidermoid cysts contain keratinized epithelium and they lack meningothelial cells. Unlike meningothelial hamartoma, like in our case, which showed the presence of meningothelial whorls and semoma bodies. Pilometricomas exhibits the basaloid cells with ghost cells, while neurofibromas display the spindle cells, which are positive for S100, which was obviously negative in our study. Hemangiomas shows proliferating blood vessels lined by CD31, CD34 positive endothelial cells. While in contrast, meningothelial hamartomas stain positively for EMA, vimentin, and PR, confirming their meningothelial origin. So the main focus for presenting this case was to, when the patient comes with a lipoma, So majority, approximately 50% of the cases which come with a small, like on the forehead, like a soft palpable lesion or a swelling. So mostly it is of, we think it's lipoma. In the OPD, it always come. Okay. So, but meningothelial hamartoma was one of the kind, like we should include this into a DD, although rare, but we should not exclude it. So yeah, next slide. Thank you. Is there any question regarding the case or anything? I'm happy to answer it.
Thank you, Mr. Chairman. Today, I would like to present my research with the title is RCT of total drain volume in post MRM breast cancer patient using socket incision compared to steward incision plus axillary anchor at Mohammad Hoesin Hospital Palembang. From this slide, we can see that Indonesia was located in Southeast Asia. When we zooming Indonesia, there is Sumatra Island, and Palembang is on Sumatra Island, and this is the iconic bridge of Palembang Bridge, and we call it Ampera Bridge. We go to the content. From the background, we can see that from WHO, breast cancer was 24.5% of all malignancy. From Globogan 2020, Indonesia has 65,000 new cases and the mortality was 22,000 people. And this mortality was the highest rank compared to the other Southeast Asian nation. In Mohammad Hoesin Hospital, surgery still the primary treatment option. There is 135 patients who was performing modified radical mastectomy at 2018. In Mohammad Hoesin Hospital, the design of MRM was steward because it is easy, but the disadvantage was there is a difficult axillary access, scar formation, and loss of axillary pole. Because of that, we developed in Mohammad Hoesin Hospital a socket design which consists of crescent incision with buried mixed mattress suture technique. And the advantage was wider exposure with better surgical care. We know that the most common complication of MRM was seroma, and seroma has increased the risk of prolonged wound healing, infection, skin flap necrosis, pain, wound adhesion, and there is a multiple method to reduce the seroma, such as negative pressure suction and obliteration with axillary anchor. Our research is aimed to compare the total drain volume between MRM with the socket design and the steward incision plus axillary anchor. What is socket? Socket is a traditional Palembang fabric as a symbol of cultural heritage and tradition. There is 4 stages of socket incision for MRM. The first one was crescent incision. The second one is fixation of the axillary fossa, or we can call it axillary anchor or axillary exclusion. After that, wound closure with rule of half pattern and buried mattress suture, buried mixed mattress suture technique. The crescent pattern was made at the starting point parallel to the axillary line, and we call it curvature Mayer. After that, we return to the starting point to the superior mamma to form curvatura minor. After performing modified radical mastectomy, we can fix the axillary fossa or performing axillary anchor by suturing the skin flap to the pectoralis major muscle and the skin flap to the serratus anterior muscle using polyglycal PGA 2NO. After that, we close the wound using the roll of half. Why using the roll of half? Because we want to prevent the duck ears like half lying cone air duct by using this roll of half pattern. How we can do that? We can do that by determining the starting point of the suture or the case suture in the middle of the curvatura major and the curvatura minor. After that, the second case suture is forming in the middle of both curvatura major and curvatura minor, and so on and so on. When we performing the suture, we using a songket suture or buried mixed mattress suture. What is a buried mixed mattress suture? Buried mixed mattress suture is a combination of buried horizontal mattress of, in the on the curvatura major. After that, we performing buried vertical mattress suture on the curvatura minor. This is the result after we suturing the flap after mastectomy. And this is the result after the wound was healed. We can see that the wound was good and there is an axillary fault there. We have already performing a research about this songket technique. The first one was the first one to see the difference between the length, width, depth, angle, and axillary fall on the surgical wound between the standard design and the songket design. But and we found that there is no significant difference. The second research was comparing the total drain volume of the steward design without axillary anchor to the songket design, and we found that the total drain of the steward design was significantly higher than the songket design. After that, we just think maybe the total drain volume of the steward design was higher than songket design because of there is no axillary anchor. After that, we just think that it's better for us to make another research by comparing steward design with axillary anchor and songket design. We know that the seroma fills the dead space to the due to the remote anatomical structure, and because the seroma was much, there will be prolonged length of the stay and increasing the incidence of infection and necrosis. Faisal et al. Say that duration of the drain placement was shorter in the axillary anchor group when comparing the control group without axillary anchor. Al-Balsi also said the same, that when there is the obliteration of axillary fossa, the drain insertion time will be shorter than the control group. Our study is a 2-arm RCT. The sample was the breast cancer patient at the surgical oncology division of Mohammad Hoesin Hospital Palembang from April to May 2022. The group, the patient was blinding and assigned to 2-arm group, songket arm and the steward arm. The eligible sample was breast cancer patient slated to perform MLM and has signed the informed consent. The primary outcome was total drain volume, and secondary objective was length of stay. This is the equipment we use in our research. From a baseline characteristic, we can see from this table that almost of the patient has a history of contraception, and almost of the patient has the stage 3 of the breast cancer. From this slide, we can see that both group was homogeneous in the age, total drain volume, length of treatment, breast weight, kemudian after that breast volume. From statistical analysis, we can see that the mean total drain volume of Songket incision was fewer or less than steward incision. It's almost half of steward incision, and from the statistical analysis, it's significant. Length of the stay of the Songket incision group was shorter than steward incision, and from statistical analysis, it is significant. From discussion, we can see that Suga et al. Said that surgical factor like type of mastectomy, using of expander, timing of surgery, and blood loss did not affect total drainage. And the prevailing consensus suggested that the performance of a single drain system had the same effect in most aspects as compared to the placement of separate channel. From Songket incision and the steward incision plus axillary fixation can reduce the accumulation of the seroma. In this study, the drain was evaluated every 24 hours after that the drain was emptied and revacuumed. When the drain was less than 50 cc, the drain was removed and the patient was eligible to discharge. And from the research, we can see that long of stay, the long of stay patient with Songket incision design technique was shorter to compared to the steward incision design plus axillary anchor, because post-operative MRM patient using the Songket incision approach had fewer drain volume than those with steward incision design plus axillary anchor. Our conclusion is that the steward incision plus axillary anchor technique had a larger total drain volume compared to Songket incision due to the varying age of participant. After that, steward incision technique plus axillary anchor having a longer treatment period, and there is no confounding variable such as age, breast weight, and breast volume had a significant effect on the length of stay. I think that's all. Thank you very much for your attention.